Hello everyone. Today we will discuss about fluid distribution and its clinical importance. So let's start our topic. So if we look at our body is 40% mass and 60% water. If we look at the distribution of water, which we discussed in our previous video, 60% out of 60% of water, two-thirds of the water is present in intracellular fluid, which is present inside the cell. So out of 60%, two-thirds is inside the cell, which is called intracellular fluid. And then rest of the one-third is present outside the cell, which is called extracellular fluid. In this extracellular fluid, 80% is present outside the cell, which is called interstitial fluid, and rest of the 20% is present in the capillaries, which is called plasma. Plasma has a lot of protein, and one of the major protein in the plasma is called albumin. So this is the distribution of fluid in the body. Now this fluid which is present in the body, it can cross the membrane because of presence of ions and change in pressure. So if we look at intracellular fluid, the major ion which is present in intracellular fluid is potassium, and the major ion which is present in extracellular fluid is sodium. Now there are two mechanisms by which the fluid can cross the membrane. The first mechanism is osmosis. So osmosis is a process by which the fluid moves from low solute concentration to high solute concentration. And the second mechanism is by change in pressure. So there are different forces which results in the distribution of fluid or movement of fluid across these membrane. So let's discuss those forces here. So the first force is, let's say if the hydrostatic pressure in the capillary increase, that will result in the movement of fluid outside the capillary into the interstitium. Second, oncotic pressure, which is the pressure because of the presence of protein. So if the oncotic pressure in the capillary increase, the protein will attract fluid. So the fluid from interstitium move into the capillary. Similarly, if the hydrostatic pressure in the interstitium increase, the fluid will move from interstitium into the capillary. And second, if the oncotic pressure in the interstitium increase, the fluid will move from the capillary into the interstitium towards the oncotic pressure, towards the protein. So once we understand the osmosis and change in pressure, we will understand that how the fluid will move across the membrane and affect the fluid distribution. There is a lot of clinical importance of fluid distribution in the body, because if we understand this whole thing, it will help us to understand what is going on clinically with our patient, and it will also help us to treat our patient in different situations. Let's discuss different situation where we will try to understand that how the change in fluid will result in will affect our patient clinically. So let's take case 1. So let's say if you have a patient who come in the hospital for dehydration secondary to diarrhea or vomiting, or maybe if the patient is not eating and drinking for a few days, which is resulting in dehydration. So how it will affect the fluid, how it will affect the fluid in the body. So if your patient has diarrhea or vomiting, the first compartment which will be affected will be extracellular fluid first. So if the patient develop diarrhea, there will be loss of fluid from the vasculature. So the plasma will go down, so loss of fluid from the vasculature. And if this diarrhea or vomiting is prolonged, more fluid will loss from the plasma, and to compensate that, the fluid will move from intracellular compartment towards the extracellular compartment. Now, when the fluid is lost from the plasma or the extracellular fluid, what kind of symptoms your patient can have? They can have low blood pressure. Because of the low blood pressure, the body will try to compensate and the heart will pump harder, which will result in tachycardia. The heart will pump harder and faster. And when you lost the fluid from the plasma, and your body will try to compensate the fluid by moving the fluid from the interstitial space and from the intracellular cells, that will also result in hypernatremia. Your sodium will go high. So how to help your patient? So you can give them normal saline, which is 0.9% fluid. So that fluid will actually go to the capillaries, to the blood vessel, and will compensate for dehydration. Our next case is water intoxication. So if someone is drinking, if someone has polydipsia, or let's say if someone has a condition called psychogenic polydipsia, they will drink a lot of water. And water is a dilute fluid because it will not match the ionic concentration of our body. So it is considered as something dilute which you are trying to drink. So if you are drinking excess water, that will actually dilute the extracellular fluid which is in the plasma and interstitial space. So the fluid will go into the vessel and it will go into the interstitial space. And when there is a lot of dilute fluid in the extracellular compartment, we know from osmosis that water will move from low solute concentration to high solute concentration. So when you drink dilute fluid, it will go into the extracellular compartment, in the plasma and in the interstitial space. So it will be diluted, and because of this dilute fluid, the water will move from interstitium towards inside the cell, from low solute to high solute, and that results in the swelling of the cell. The cell will swell up, and if this happen in brain, it can cause swelling of the brain cell, which can sometimes lead to seizure. Because you are also diluting the extracellular fluid, which has, and the extracellular fluid major ion is sodium, so that will be diluted also, which will also cause hyponatremia. Sodium will be low. So how to treat these patients? So number one is we will suggest water restriction in these patients. Okay, our third case is, let's say if your patient has hypoalbuminemia or low albumin level. We know from our concept that most of the albumin is present in the vessel or in the plasma, and albumin is responsible for oncotic pressure. So wherever the albumin is, wherever the protein is, water will move towards albumin because it will keep the pressure normal. So if someone has hypoalbuminemia, so if someone lost the protein, let's say the example is in nephrotic syndrome. In nephrotic syndrome, patient will lose albumin. So if the albumin is low in the capillaries, it will result in loss of oncotic pressure. So the fluid will shift from plasma towards the interstitium because there will be low protein in the plasma, loss of oncotic pressure. The fluid will move towards the interstitium, which might have more protein. And when it moves towards the interstitial fluid will get higher, and that would result in swelling or edema. Sometimes ascites can also happen. So because of this swelling, sometimes you might have to use Lasix depending on the situation. You have to use diuretic. Our next case is diabetic ketoacidosis. So if someone is diabetic or if someone has diabetes, their glucose in the blood will go high. So let's say your plasma or the extracellular fluid has high glucose. We know for the fact that water will move from low solute to high solute concentration. So the glucose is high in the capillaries or in the blood. So water will move from interstitium towards the plasma and from intracellular to extracellular fluid, and that will result in massive osmotic diuresis. So water will move from low solute to high solute concentration. When wherever the glucose is, water will be attracted towards the glucose, move from interstitium and intracellular fluid towards the plasma, which is a part of extracellular fluid, and that will result in severe dehydration. Because of high glucose in the capillaries or in the blood, it will also lead to high osmolarity. So how to treat that? So in patient with diabetic ketoacidosis, we have to give them a lot of fluid to avoid dehydration. And second thing, we have to decrease their glucose, and that we do by using insulin. Okay, our next case is when we use hypertonic saline, what happened? So when you give your patient hypertonic saline, the concentration, the osmolality will get higher in the capillaries or in the blood. So water will move from low solute to high solute concentration. So the solute concentration in the plasma will be high. So water will move from interstitium and intracellular fluid towards the plasma. So this will result in decreasing cerebral edema. How? So let's say you have a patient who has brain bleed. So let's say this is a bleed and this is a brain. And brain bleed will actually compress the brain cells and the capillaries in the brain, and some of the cells will get compressed and get bigger. So there will be capillaries around those cells also in the brain. So when you use hypertonic saline, the concentration, the osmolality will get higher in the capillaries, and water will move from these swelled cells towards the capillary, and that will help to reduce the swelling of the brain cells or the cerebral edema. So that's why we can sometimes use hypertonic saline in patient with brain bleed if they have high high pressure or brain swelling or swelling in the brain, uh, or in patient with high intracranial pressure, hypertonic saline. Okay, our next case is if we have a patient who have a burn injury. So what happened in patient with burn? Burn will result in increased vascular permeability. Increased vascular permeability. So let's say if someone has burn, the vascular permeability of this capillary will increase, and fluid will move out from plasma into the interstitium, and that will result in extracellular fluid loss. So that plasma can be trapped in interstitium and sometimes can result in edema because you are losing the fluid from plasma. You can have low blood pressure and also have hemoconcentration. So the burn patient also require lot of fluid, so you can give them normal saline. Okay, our next case is if someone has congestive heart failure. So let's say if someone heart is not pumping properly, that will result in backing up of fluid, which will actually go towards the lung. So your lung will fill with fluid, and if the heart failure is severe, it can actually go back into the abdomen or into the legs. That will result in pedal edema. So leg swelling can happen. So these patients can have lung edema, interstitial edema, pulmonary congestion. They can have pulmonary edema, and as the pressure continue to go backward, there will be increased pressure in the capillaries, and on the other side, the venous pressure will also increase. They will have high venous pressure because the heart is not pumping properly, and the fluid will be back up into the body on the venous side. So because of the high venous pressure, some of the fluid will get leak out into the interstitium, which can result in interstitial edema or pedal edema. So that's why in patient with heart failure, to get rid of the edema, we use Lasix. These were the common cases which we see because of the distribution of fluid in different compartment in different situation. It helps us to diagnose our patient, and it also helps us to understand what is going on with our patient and help us to treat our patients better. Thank you so much. Have a nice day.